Right, we've now started our Ledderhose webinar, and Gary Manley is our first speaker. Gary, over to you.
Brilliant. Right, so I am a Ledderhose patient. I first noticed the condition when I was about 20, which is 13 years ago now. And it was just sort of starting to get a pain in the bottom of my foot. Initially, I thought it was just plantar fasciitis, and that's actually what the GP treated me for. But then found the lump, so I went back again, and they diagnosed it as being Ledderhose or plantar fibroma, whatever you want to call it. And I got sent off ultrasound, I think MRI at one point, and then they then decided to do an ultrasound guided steroid injection, and so I went along with that, and it actually helped for about 6 months, but then it came back with a vengeance after that, and was much worse. To the point I was really struggling to walk. Started using a walking stick for about a year. I was using that, and then my wife actually came across radiotherapy and the British Dupuytren-Society, so we looked up all the research on there and ended up going to see Dr. Schaefer, I'm never sure, he'll say later, and yeah, had a consultation with him, and everything went really well. It sounded really good, privately, should add, and yes, so I went and had 2 weeks of treatment, separated by about 8 weeks, I think it was, in Guildford. And I think during the first 8-week period, so between the 2 weeks of treatment, it actually sort of got worse, got slightly more inflamed, and I was reassured that was fine. That was quite often the case with radiotherapy. And then I think it's about a month after the second week of treatment, for me, it started getting better and just continued to get better for a good 6 months to a year, to the point where I'm basically pain-free now, unless I tread on a bit of Lego or something, but that hurts everyone. So yeah, and I actually took up running about 3 years after I had the radiotherapy, and run marathon, lots of 10Ks and things, and get on with that quite well, and don't really have any problems from it anymore. Whilst I was, I did a lot of research initially when I was looking into treatments, because at the time I was working in a lab doing scientific research, so I had access to all different journals and what have you. So I was looking at all the different treatment options and the science behind it, because that's the kind of geek that I am, and found it really interesting. So I started up the Ledderhose Disease blog, and through that ended up becoming a trustee for the BDS. And yes, gave a presentation at the symposium in 2015 on patient surveys that we've done about the different treatment options for Ledderhose. And again, radiotherapy came out well, but I did a few other treatment options as well. And yeah, that's pretty much my whirlwind story there. Obviously, if anyone has any questions about this, they can email in, and happy to answer them. Or if anyone has any questions here, happy to go in more detail. But
just to say, you just got a question. If you go in the F&A section on your little computer,
oh yeah, Q&A.
We'll find a question there.
Thank you. Oh yes. So the question is, do I still have physical bumps? The answer is there's still a very small bump there. It hasn't changed in size since about probably a year after the radiotherapy, but it did noticeably shrink during that year. And nope, they're not getting any larger from the running. It hasn't changed, as I say, I guess since 2013, so 7 years now. And it's 8 years since I had the radiotherapy. That was in 2012 that I had that.
That's good going, Gary. Okay.
Another question as well. Is there no pain anymore? No, say not really. Occasionally, if I tread on something, that spot is more sensitive than any other part of my foot, but there's no, I wouldn't say, there's certainly nothing debilitating about it anymore. Standing around for long periods of time, so when I've been to theme parks with my daughter and what have you, I can start to feel it after a couple of days of doing that, but as long as I've got somewhere to sit every half hour or so, it doesn't cause me to live my life any differently to what I would want to. So
Right. don't think there's any further questions. So then we'll go to the second speaker of our webinar, and that's Dr. Marcus Maden-Tilson.
Lovely, thank you very much. Just for the people who don't know about me, I work down in Thanet, which is the southern eastern corner of England. If you get any further east or south, you get wet. I serve in a community of about 150,000 patients. My practice has about 12,000 patients. But the way I came across Ledderhose disease was really through my MSK ultrasound scanning I'm doing. And that was the first time in my now 15 years as a GP that I came across this. So it is a rare disease, and I've seen so far now 6 patients with this condition. So typically, as Gary actually alluded to already, the most patients come up with a painful lump. They can feel, often some even haven't been really aware of the lump. They just felt pain in their foot. And on examination, you find this beautiful little thickening of the fascia. And a lot of colleagues of mine do diagnose usually that as plantar fasciitis. And the scans the scan requests I had were all about, is this plantar fasciitis? And then I could basically from the request already say, no, it's not. It's obviously Ledderhose disease. And every time I cheer because I don't see it often, it's nice to see. Not so nice for the patients. So as part of that, and with George's help, I actually undertook a couple of injections. And yes, it's very important if you do inject them, have a Lerlock syringe, because otherwise you got the steroid in your face. Yes, the patients can suffer quite a lot. So we've got a couple of patients, and as Gary already said, you know, sometimes even walking on a stick. And as if any physiotherapists are watching, you know, the kinetic chain, i.e., you know, the ankle, the knee, the hip, and the back, and even the shoulders can be affected by it because they're not walking straight anymore. So it is important that that is also recognized and treated properly. So the diagnosis with ultrasound is fairly straightforward, and I sort of feel tempted to call it pathognomic because the appearances, and I'm going to share that on the screen if I press the right buttons, is more or less pathognomic. You see the on the screen now, hopefully. Can someone confirm that they see it? They see this beautiful little hypoechoic nodule within the fascia, and it has a nice, beautiful little cloudy appearance. And you also see that below it, the area appears to be slightly brighter. So that's all fairly typically, and also typically it doesn't have any perfusion within. Oh, I'm not sharing it. Now I'm sharing.
Now you're sharing it. Yes, come on now.
I'll try again. So you see this nodule here. Can you see the pointer?
Yes.
Lovely. So you see this hypoechoic pointer, the hypoechoic area here, and you see how it's brighter below it. So that's sort of enhancement, posterior enhancement. And you see this sort of cloudy appearance in the ultrasound. And there's hardly anything else you would find with that appearance on ultrasound in that particular area, particularly with that history, a slow developing nodule. I can imagine that if you have an injury to the tendon and you have a hematoma, it might look similar, but you know, the history would strongly suggest that. So again, I think from the history plus the ultrasound, it's very easy to diagnose. So I had the pleasure to inject a couple of patients with that condition, and I used Dupuytren, and on one patient this has worked quite well, and there was no recurrence so far. I mean, we are now a year in. The other patient had, a bit like Gary, a relief for about half a year, and then they became painful again. I'm not quite sure what the GP then decided to do. I did, when I wrote the report, that obviously radiotherapy is one of the options, and other injections can also be options, but I think the other clever clots a bit later will tell us far more about that. So that's really my little spiel. Unless there are any more questions, I'm happy to answer them.
There is an open question in the Q&A chat box.
Yes. I think that's probably a question which will be better to be answered by the clever clots a bit later. I think from my point of view, I suspect there are quite a lot of people running around with Ledderhose not really knowing what it is. And if they don't have any pains in the nodule, then it's probably not really worth doing much about it. Whether they would cause numbness, I mean, this would then really require a good examination of the foot to ascertain exactly where that numbness is. The plantar fascia in itself is has nerve tissue or nerve fibers, so it may cause a bit of numbness. But if you had numbness in your toes, then I suspect that probably has other reasons. Why ultrasound? I see another question there. The ultrasound is really quite easy and readily available and far cheaper than MRI. And I know that MRI is seen to be the gold standard in investigation from that point of view. I personally think the appearances and the history together are so clear that I don't think there would be an MRI required unless you need to have it for preoperative preparation. For the initial treatments with the injections, I suspect that would be enough. And also ultrasound is beautiful to actually do guided injections at the time. So you can make sure that the needle sits right in the middle of the lesion or pepper around the lesion. So from that point of view, I would go ultrasound, but obviously I'm biased because I'm a sonographer as well as a GP.
There are a couple more questions there as well.
Yeah, sorry. Why did I use? Well, I blame George. He advised me to use Dupuytren because it has little crystals and they should last a bit longer in their effect. That's the idea, really. There are quite a few other options of injections you could use, but again, I'll leave the other to explain that a bit further. Hi, Ed.
Hi, how are you? I've got you on my phone, so I've given up the computer at the moment. So,
just to come back, just to add to Marcus, because he's completely correct around the numbness question, because I know we've dismissed it. What we do sometimes find, and I'll come on to my talk in a minute, but I'll quickly share it with you. There's a graphic picture coming up for those of you that don't want to see a graphic picture. There's a staging system. It's an old staging system. But as you can see here, it ranges from this one on the left, where you've got a little nodule, and sorry, again, these are graphic pictures, all the way through to this one on the right. And those nodules are thankfully rarer, but they're multiple nodules and they involve the skin. Now what we have found with fibromas or Ledderhose disease is whilst they're obviously a benign condition, they're locally quite aggressive. And so what you'll sometimes find is that they can irritate something called the lateral plantar nerve. And so that's a nerve that runs along the inside bottom of the foot, and it supplies the nerve innervation to that part of the foot. So if they do irritate that nerve, you can get numbness with that as well. And equally, you can irritate that nerve by doing the injections, hence why it's very good to do under ultrasound guidance. So just a little bit to add to that. So I'll start my talk.
More questions coming in. The one says,
yeah,
I think we'll come up later. Does anyone use enzymes instead of steroid injections? That will be covered later.
Steroids can increase the size. Funny enough, the one patient I did injected felt the lump was getting initially bigger, but much softer, so therefore not bothersome. It got a bit smaller then again. Unfortunately, now she has also more pain with it as well. Again. Yeah,
and I find some of the findings to Marcus in that sometimes well, it's the steroid, and I think it often depends on what stage they're at, and there's a lot of debate around staging of these lumps. But if they're in the stage where they're very active, what we call proliferative, sometimes a steroid can halt that in some ways in the early stages, and they do make it softer. But going back to the question earlier about did you ever get rid of the lumps for Gary, I think often what I will tell patients is it's quite rare to completely get rid of the lump en masse, and often it's that they are then manageable and softer, really, rather than getting rid of them completely. Would you agree, Ed?
Yes, and I think what we find is that with the injections that I'm using, the larger ones are actually much easier to treat than the small ones, because what happens is on large ones you have a repository effect when you're using your injection. As they get smaller, you no longer have that repository effect. You're getting more leakage, so getting those very small ones to completely go away is difficult. My approach is really to get them as small as possible, and then really try to continue the process with verapamil cream. Because again, getting that last little bit to go away. But then again, our goal is not cosmesis; it's primarily to get people comfortable. So if we get them small enough and they can control it with verapamil, control some regrowth with verapamil, I think I think we've been fairly successful.
Good. We've got another question, but I think it might be time for George to take over.
Okay.
Do his talk, and then we'll go to the next lot of questions. So
I'm George. I'm a consultant podiatric surgeon, which basically is a podiatrist that operates on feet. Ed's also a podiatric surgeon, but there's a little bit difference between here and the US. So I see the whole range. So I have a lot of fibromas generally sent to me, and that's either through the BDS or through people know that I'm interested in it. And, they fall into two categories for me. Well, actually three. There's ones that actually have been, because I found anecdotally, and there's a little bit of evidence for this, that actually they run in line with plantar fasciitis often. So you'll find that some patients, particularly if they have what we call a proximal one. So proximal basically means it's further up the foot towards the heel. And so if they have a lump that's further towards the heel, then sometimes they do have pain at the insertion of the fascia, which we would sometimes classically look at plantar fasciitis, as well as the lump itself. And in some cases, we never feel the lump. So the lump is what we call non-palpable. And what we find is been treating that patient as plantar fasciitis. And then when they have a scan, we actually see that they have fibromas near the insertion of the fascia, which is much harder to actually feel because practically, there's more fat in that area, so you just can't feel them as well. However, so that's one category, and those are the ones that really struggle at first because, like Marcus was saying, most of these lesions are diagnosed in primary care as plantar fasciitis because it's pain in the plantar fascia. So often it's diagnosed as that. And those patients continue to be diagnosed with that because there isn't an obvious lump to see. And then you have the second cohort of patients who have a lump, typically where a lot of the people who you're watching will have it. And you can feel it and you can see it and it's tender. And then there's the third, which is quite rare. And some of the other guys might be able to elaborate on this a little bit, is I've seen now 3 patients, because obviously we compare plantar fibromatosis to other conditions that are similar, one being in the hand, which obviously Dupuytrens. And I've seen 3 patients who've all had clawing of their big toe, like you get with fingers in the hand, and they've all been non-weight bearing patients. They're patients who are in wheelchairs, wheelchair bound. And I think there's something anecdotally in the continued weight bearing that stops the cord development, which you classically get with Dupuytren. So those are sort of 3 patients. Now, in the NHS, from my perspective, I'm a surgeon. So when people refer these lumps to me, they think we're going to cut them out. And actually, it's the last thing I want to do is cut them out. And that's because they have such a high recurrence rate. So there's some papers that quote up to 100% recurrence rate. And what often happens, as we were saying before about the numbness, when they do recur, what we have to remember is that this condition is linked with excess scarring, connective tissue disorders. And so if you then develop more scarring in the area, not only may you develop more of the fibromas, and often you get them back multiple, but also you get problems with scarring, and it envelops the whole area, and then you can get with nerve pain. Now, don't get me wrong, I've seen patients historically when we used to cut these out, and they've done well, but they're few and far between, and that's why really we push to treat them non-surgically. And it's why often it's good if you get referred to a surgeon, that you've seen a surgeon that is specifically regarding the foot, because often what can happen, particularly in the NHS, it may not happen in the US as much, and I'm sure I can cover that, is that you go to a lumps and bumps clinic in the UK sometimes. And often what can happen is that you're seen by a general surgeon, and through no fault of their own, they see it as any other lump and bump, and they'll remove it. And then it ends up with problems afterwards because it comes back. And so what we offer, so often a community podiatrist will see them, and the first treatment always is to just simply offload them. So if they're sore because the nodule is hard and tender, then you offload them with an insole. And it's often, patients don't often like that so much because you're not seen to be doing an active treatment. You're simply offloading the area. But actually our aim is to never get rid of these lumps particularly. And Ed might argue some things, particularly as topical issues. But with me here, with the limitations we have around some of the medications, my aim isn't to necessarily make them go away. It's to make them manageable so they're not sore. And so then moving on from there, we try steroid injections. So we do ultrasounded steroids. And actually, I need to speak with Marcus later because I've been using depamedrone for a long time. And actually, I've switched to Kenalog, so triamcinolone. Mainly because if you look at any of the papers around steroid now, and it's particularly US papers, they'll all use Kenalog. And it seems to, again, anecdotally, and I'm hoping to try and present this at the international conference this year, it seems to have a slightly better effect in the short term initially, anyway. And then after that, if they've seen me and they've done injections, then we have a few options, and some of those options are a bit of a trial option, but because I have it there, we will try it. And there are two poster presentations, and I know of one study that looks at something called shockwave therapy. Now, I don't have in my mind whether shock therapy works or it doesn't work, but because it's got a very low risk attached to it, we have shockwave in my department, so we will try shockwave therapy. And for a few patients, it's certainly helped with pain. It hasn't got rid of their lesion at all, but it's certainly helped with pain. And I think because an element of it might be an issue with the fascia, then it's had an effect on that as well. And then from there, if that still isn't working and it's having a considerable effect on your day-to-day living and you're walking around, that's when we look at other options. And that's really where we come on to Richard's radiotherapy. Or there are some cases we will operate. And if patients are really in untold amounts of pain and we've tried everything, then we're not left with many other options than to operate. But it's really my last option, and it's something I very rarely like to do. In the NHS as a whole, it is a bit of a postcode lottery, unfortunately, because depending on where you go, depends on who you will see and who will know much about them. Now, luckily, if you're in Kent and you've got Marcus as a GP, he's probably going to be one of a few GPs that tend to know about these significantly off the bat. And again, same with the general surgeons, it's through no fault of the GP that it's not necessarily their role to be specialised in bits and bobs that happen in the plantar fascia. And so often, what a lot of you will have found is that you take a long time to actually get to someone who knows who it is, or what it is, or a treatment for it. And even if you see a podiatrist sometimes, I do a lot of lectures to podiatrists, it's still quite hard for them to diagnose what they are and what to do with them. And so particularly in this country, I think there's a lot of people who go the long way round to gaining treatment. And I think that's the initial difficulty, unfortunately. I'm just going to have a look at a couple of the questions and answers just while we're here. I'll let Ed answer. Well, actually, I'll let Anne answer the verapamil thing for the UK. So the different steroids. So this is what I was talking to Marcus about. So there's three main steroids we use. There's lots of different ones. There's three main, and there's one called dexamethasone. There's one called depamedrone. So dexamethasone, depamedrone is also known as methylprednisolone. And there's something called Kenalog, which is known as triamcinolone. And they vary on what they are. Now, I've said them in that order on purpose because dexamethasone, the steroid, is quite a water-soluble steroid. And so when you inject that, It's quite potent, but quite water soluble. So in fact, it's very good for scars and keloid scars and things. Whereas the Kenalog, historically, I don't use on soft tissue a lot. I'll only use on joints because sometimes it can cause atrophy. So it can have a significant impact on fat. And the foot, which is my area, is the one place you want fat. And so often I won't use Kenalog, but I have started using it. What I would say is I probably wouldn't go to your GP asking for a particular steroid, because actually the GPs most of them will be well versed, and Marcus can say, in what steroids do what. And I think it's a case of more so asking about steroids and whether or not they would do them or refer on for it, because your GP will be more than well versed in all the different steroid injections. So cryoablation, thank you for that question, Eric. Cryoablation, I don't know if any of the other team know about it. Now, I only know of one area in the country that's doing it significantly. There's a place called the Barn Clinic in Sheffield. Now, I don't have much data off my head about cryo. The problem with cryo, as it stands at the moment, and the main concern I have with it, is that it's being done generally by practitioners that aren't surgeons, and so they're making little cuts and putting a cryo probe in, and then they're not really sure what's happening. They do it under ultrasound guidance, but the outcomes of cryo we just don't know enough about at the moment. And the problem is, because it doesn't only just affect the lesion, it acts locally. Again, there's that issue around causing damage to a structure. Now, again, what I would advocate is, if you are in so much pain and you've tried everything we have in the UK here and you don't want surgery, then potentially cryo is an option. But certainly from an evidence-based medicine, which is what we like to look at, there's just not a lot of evidence for cryoablation at the moment. And then just the last one, so the orthotics, I'm sorry, I'm seeing a lot of these guys. The orthotics, absolutely wear orthotics. So wearing orthotics is a good thing, and not your standard orthotic, because your standard orthotic is largely to support the medial arch. There's loads of difference, but the ones you would get over the counter. Whereas you want an orthotic that actually has a mechanism inbuilt to offload that lesion. So that normally means you have to see a podiatrist or someone like that who will help you out with that. And the other I'll leave for Richard. Mike is the scar tissue comment that gets crazy. Yeah, absolutely. So the scar tissue, absolutely, with the cryoablation and the surgery. So the scarring, again, I think scarring is an issue for most of you guys who have problems like this, because it is a scarring problem as well. So certainly, yes, it's an issue, but it is with a lot of these treatments. And that's me done for now, Anna, until we answer any more.
Right. There was a question about verapamil. It's not generally available in the UK, but it can be ordered if you get a private prescription. You got to email the private prescription to a company that will then order it from the US. You got to order 3 months at a time, and it would cost around about £500 probably for the 3-month supply. And I don't think your insurance would cover that. But there is a way around it not being available here, but it's not an easy one. Right, more questions. Eric wants to know if you need to hole where the fibroma is in your orthotics.
Yes, yes, absolutely. And that's what I was saying. So largely you need what's called a bespoke orthotic, just to help. Now, any soft orthotic that will help the arch of your foot may help, but it's better to have a cutout. I mean, there's always a bit of DIY you could do yourself, but I wouldn't necessarily recommend that. I'd say go and see a podiatrist or a physio or something for that.
Who are the best people to go to for orthotics?
Well, theoretically, podiatrists. Podiatrists by and large do the bulk of orthotics in the area. Orthotists. So there are people called orthotists as well. The problem with orthotists, they do fantastic orthotics, but often they need a referral to them to give the orthotic, because often even the private companies, you don't many orthotists working from. You can just visit them and see them. So if you can find an orthotist or a podiatrist. Physios do give out some good insoles, but they don't specifically treat this condition. So I'd say a podiatrist or an orthotist would be the best.
I would like to sort of butt in there a bit as well. One of the difficulties we have with the referrals is that, again, if you don't get referred for the right conditions, that might be difficult. And unfortunately, in our area, I don't know how it is in different areas other than Kent, you will have a long waiting time of at least 4 to 5 to 6 months before you actually get to see them. You need to keep that in mind.
Absolutely, and you know, even in my own area now, I was in Blackpool, which was much better, but now I'm in Northampton, and you actually can't see a podiatrist. It's not a commissioned service anymore. So we actually I send most of my patients, if they need orthotics, to the university podiatry clinic, because we have a local university that trains podiatrists, so they treat as a discounted rate, but it's actually not offered on the NHS anymore.
Stretching and massage.
Let's have a look.
So I think to that, I would say it may relieve some of the pains when you stretch your plantar fascia a little bit. But I think overall, when the lesion is big enough to give you pain, then I think it's not going to do very much. Would be my answer to that. I don't know what the other guys want to say. To the answer of Jill, in terms of can the injections cause scar tissue too, this is one of the risks you have. And this is also where the placement of the injection is really quite important. And that's why it also should be done with ultrasound. Now, you could make your point that the lesion is usually fairly obvious to see, and therefore you should be able to point the needle well enough into the lesion. And if you have quick resistance, you know you're in it. But I would also now suggest that ultrasound guidance would be better in that situation.
Right. There's a question about adalimumab. I don't think that is known yet. I think it's too early to say. We're still waiting for the trial research for the Dupuytren's nodules.
Yeah, the only thing, and I think theoretically, if you was to read it, yes, maybe, but in actual fact, particularly for Ledderhose, there's a couple of papers for patients who are actually on anti-TNFs who got Ledderhose disease while they're on them for rheumatoid arthritis. So yeah, jury's out.
Right. Dietary suggestions and supplements. That's a difficult one. I don't think anything is proven to help.
I think we probably could do with a study on that, because as a general fibromatosis, I suspect I don't know whether there are any studies in regards to Dupuytrens or frozen shoulder or Ledderhose from that point, because they're all sort of thought to be a similar process. I don't think there's any data at all which would help us here.
Anecdotally, I found a low carb diet helped, but equally I saw substantial weight loss with that. So, and other patients have reported the same to me, but it's a handful. So,
I would be fairly callous with that, and probably the weight loss had more benefit than anything else in that regard.
absolutely, yeah.
I think that the questions, there's a couple of questions around insoles and their variable ability. Again, the one thing I always say to patients when I'm sending them to a podiatrist is that, unfortunately, in some ways, orthotics are as much science as they are an art in some cases. So whilst there's some evidence behind them, and orthotics are often made either bespoke or modified off the shelf, you will always find there are compensations to be made, or you'll find that they just don't fit you and they're not very good for you. And if that's the case, then that's a standard part of the treatment that you sort of ticked off and it's not work for you, and then we look towards moving on.
Right. Any questions we don't get to, we'll try and answer them afterwards. I think we might say, let's ask Dr. Richard Schaefer to talk now, and we can always type some answers to the questions as they're coming in.
Fantastic. Thank you, Anna, for allowing me to talk. So I'm going to talk, basically try and put this in a little bit of context in terms of generally about radiotherapy, radiotherapy for non-cancer conditions, and then talk specifically about radiotherapy for Ledderhose disease. So what I'm going to do is share my screen, and let's see if we can get that going. Okay, yeah, let's just, sorry, what I'd like to do is...
It's working.
Yeah, you can see it, but what I'd like to do is, so stop the share and then actually put it on the actual show. Here we go. So, can you see it now?
Yes.
Fantastic. Okay, great. So now what I'm failing to do now, of course, is actually work the presentation. There we go. So just to say that you know, radiotherapy is the use of X-rays or particles such as electrons to treat disease. And most radiotherapy, at least in the UK, is used for treating cancer. And we use very high doses. So we use grey as the dose of radiotherapy. And we use about 60 or 70 grey, just very roughly, to treat a cancer. But we also use radiotherapy for treating benign, in other words, non-cancer conditions and benign tumours. And that's for two reasons, very roughly. First of all, it basically stops stuff growing. And the second thing is it reduces inflammation. And we tend to use quite low doses for those reasons. And rather than 60 or 70 grey, it can be anywhere between 3 and 30 grey. And for that reason, side effects aren't really a major problem. So just talking about benign radiotherapy in the UK, because you might know in Germany, they use a lot of it. I mean, 20,000 treatments a year. So up to the 1950s, they used to use it for all sorts of things. But from the 1950s onwards, there was a decline in use. And that was due to a number of factors. First of all, there were new medical treatments, for instance, for arthritis, improvements in surgery. And then there was this fear generally of radiation and radiation-induced cancer. And this fear of cancer was really based on conditions that we no longer treat. So tinea capitis is ringworm, and they used to treat ringworm on the heads of children with radiation, which we would never do these days, and it caused brain tumours. Similarly, this condition called ankylosing spondylitis is a sort of arthritis of the back, and again, they used to treat that with radiation, and that caused leukemia because that's where the bone marrow is, and that's where the actual blood cells are made. But we don't do that anymore at all. And of course here, we're talking about just treating the feet, and there's not bone marrow there, it's not over the brain or anything like that, and generally we tend to use it for patients who are older, or at least not children, so it's quite a different sort of situation. So in 2014, a group of us got together and did a survey of how much radiotherapy is being used in the UK for non-cancer conditions. And remember I said that in Germany they treat probably 20,000 a year. We found that we probably treat about 250 a year. So very, very tiny. And that was for various conditions. We talked already a little bit about keloid scarring. I won't go through them all in detail, but Dupuytren's and Ledderhose disease was in there as well. And other types of radiotherapy as well. And then from probably about 5 years ago for now, there seems to be a resurgence in use. One of the reasons I think was, again, our group wrote this, this document, which you can find online if you Google radiotherapy benign or something, or RCR, radiotherapy benign. You'll get this document up and it takes you through the evidence for radiotherapy for various conditions. And then really interestingly, I think patient demand really has driven this as well. So I think the British Dupuytren-Society and other groups have really made more demand for this and therefore brought it to more people, more doctors' attention. And then the last thing I would say, and this is by no means a comprehensive list, is that we also reviewed the risk of radiation-induced cancer with these sort of doses of radiotherapy. And we found that, you know, in terms of the evidence, it was a very, very low risk. So let's see a typical example. So this is a 65-year-old lady. She had advanced Dupuytren's disease in both hands, and you probably know that Dupuytren's and Ledderhose are basically the same disease, but one happens in hands, one happens at the feet. And she developed painful nodules in both feet, and she could only walk for short distances on level ground. I then treated her, and I'll show you some details about that. And then 3 months after radiotherapy, she said she was delighted with the results. She was able to walk miles on uneven ground, and the nodules were much smaller and softer, and she had no side effects from it. So this is her feet, and I've drawn around it just on PowerPoint. You can see that basically that's the main region, and then there was some thickening of the plantar fascia as well, which I also thought was relevant. And I basically drew effectively just a rectangle around it, just to make sure that I treated the whole thing. We then make a sort of a lead shield, so that we are treating that area, which I've denoted by that oblong, but we're not treating the area around it. And this lady I treated with this machine. That's obviously a gentleman having his hand done. This is a very simple machine that we use with x-rays, but I tend these days to use electrons. And it's nothing to do with the fact that one's better or worse. It's just depends which ones you happen to have available in your hospital. So the treatment takes 10 minutes a day. It's totally painless, and you continue with the normal daily activities. So you can work, if you're able to, of course, you can walk and you can run. So the details of the treatment. So 15 gray, remember gray is the radiotherapy dose measure. So 15 gray and 5 fractions. Now a fraction just means a treatment. So that means 3 gray per treatment and 5 times. So it would be Monday, Tuesday, Wednesday, Thursday, Friday over 1 week. There's then about a 3-month break and then a further 5 treatments. So that's 10 treatments in all. And we give in total 30 gray. So that's basically how we do it. And the reason why we do this is because the evidence basically comes from the literature, and this is the main study really. There are other studies, but Professor Siegenschmidt in Germany did this study, and it was basically more than 150 patients between 1997 and 2009, and all patients had to have progression for at least 6 months, in other words, worsening of the disease. They had to have increased nodules or cords or symptoms, so that's what really he meant by progression. And most of them had also had other treatments. So this isn't a first-line treatment. So I absolutely agree with everything that Marcus and George said. Normally they would have insoles, steroid injections. Often they have painkillers as well. And the average follow-up time was 5.5 years. So basically they were told about the options, and the patients were allowed to choose which treatment. So this is not a randomized trial where people were said, well, you're randomly going to have treatment or not. But this was really a case control, a case series. And some people chose, don't want to do anything. Some people chose just the conservative management. Some people chose surgery, but of course some people chose radiotherapy. In fact, more than half of the people chose radiotherapy, and the other ones formed the control group. So the control group being those who did not have radiotherapy. And these are the results. So basically, the main figure here really that sort of shows most of the figures is, first thing to say is, in the control group, in other words not having radiotherapy, there was still a number of people who got better. So about 20% of people got better without treatment, or without what was thought to be effective treatment. But obviously in the radiotherapy group, about 70 or 80% of people got better in terms of their symptoms getting better, less pain on walking, less pain at rest, and also improved walking. We call that functional improvement. So in terms of the side effects, so within 3 months after the treatment, we call that acute side effects. About 1 in 4 people got side effects with mildly red or peeling skin, or sometimes redness or peeling that was worse than mild. But in the long term, 16% of people got it with mild skin changes, including dryness, but nothing more severe. I normally say to people that they might notice that their skin feels a little bit rougher or a little bit smoother, and it can be a little bit thicker or a little bit thinner. And then this is obviously an important thing. The risk of cancer from radiation for a 50-year-old is about 0.02% lifetime risk. And that's of forming a mild skin cancer called a basal cell carcinoma, which can be cut out. And that's by 30 years, which is the average time it would take to form. So obviously, it's very important when anyone sees me that I do tell them what the risk is. If they're, let's say, 70 years old, then I would say, really, your risk is so negligible, then I would say it's virtually zero. Whereas if someone's, let's say, in their 20s or 30s, then the risk would be higher. Always difficult to say exactly how high, but let's say increased by 10 times. So that would make it maybe 0.2%. But again, it's just a benefit risk situation where you think about, well, what's the benefits of getting the treatment, or the potential benefits? Of course, not everyone gets the benefits. And what's the potential risks? And of course, you know, there are benefits and risks to every treatment. So, but as I say, with a younger patient, I would have a much more in-depth discussion about that. So I looked at my patients, this is a few years ago now, and over 5 years, I wasn't treating that many people, but I found 52 patients that I treated. 24 patients returned the questionnaire. So I was sending questionnaires at 3 months and then every year after that. And the average follow-up in these patients was just over 2 years. And the indications for treatment, most people had pain, some people were less able to walk, and virtually everyone had growing nodules. And these were my results. So you can see that the reduction in pain was 71%. And just to say, that was within the range of what Schmidt found. The overall improvement was 79%, which was exactly the same as he found. And the functional improvement, in other words, in the ability to walk or run, was virtually the same as what he found. So all I'm really saying is that my results are basically exactly the same as they found in their study. So no better, no worse. Now, this is something that Gary and probably Anna will be able to talk about more than me, but I thought this was a really useful slide. Just to say that Gary and Anna did a survey of more than 1,000 Ledderhose patients. And this is just to show, in green, you can see the patients who felt that each treatment was good. In red, it was about the patients who thought each treatment was bad, and obviously in the middle, it was basically neither good nor bad. If you just look for radiotherapy, the green bar is larger than the other green bars. In other words, radiotherapy seemed to be better accepted than any of the other treatments. And in terms of those who felt that it was bad, about 15%, and only cryosurgery, although there weren't many patients, they had better than that in terms of who thought it was bad. On the other hand, not as many people thought it was as good. Really what I'm trying to say here is that radiotherapy was perceived by patients to be a very good treatment, as well as the evidence showing that. So thank you for letting me speak. Any questions?
Well, as a GP, you know, for me, using radiotherapy on a non neoplastic condition is a fairly sort of novel idea in a way. I mean, I've read, of course, in this context about that. So I assume that we would be able to refer directly into radiotherapy departments for that sort of treatment.
It depends what you mean by refer directly. So I used to work on the NHS and privately, and I now actually only work privately. So I can't really talk about NHS departments. And unfortunately, I was never able to get funding for NHS treatments, although I understand that other people are. In terms of referring to myself, it's very easy, a referral letter, or very often patients find me and refer themselves. But Anna might have more information about referral patterns and pathways elsewhere.
I'll just pop in. I don't have Ledderhose, but I do have Dupuytrens, and I did get a GP referral for radiotherapy at my local teaching hospital.
So just looking through the questions, right, what are the pros and cons of radiotherapy? I think I probably covered that one. If you've already had radiotherapy, does that make it harder for the injections to be effective? Well, what I would say, not quite to answer that question, because I don't do injections, I would say that certainly for Dupuytren's disease, so in other words, having it on the hands, if you've had radiotherapy, there's no evidence that surgery works worse or is more risky. So it might be that other people have something to offer in terms of the injections, but I suspect that it doesn't really make any difference. So just going through the questions again, there's Jonas who says, I had radiotherapy for Dupuytren's disease and had a strong reaction 4 weeks after the radiation with blisters and pus and burn-like symptoms, took cortisone cream to manage it. Is this common? What are the overall worst case downsides of radiotherapy in the treatment of young patients? So I think that's a really good question. So I did slightly skate over those patients who get a worse than average side effects. Now, I mean, for Dupuytrens and Ledderhose combined, and it's pretty well the same thing with the same doses, I have had, I think, amongst about 500 or 600 patients, about 3 patients I remember very well who had an acute reaction, in other words, reactions in the weeks after radiotherapy that were more than I expected. In other words, getting blisters or, you know, really very red hands or feet. And it's difficult to say who those patients are going to be. And it can be for various reasons. First of all, there are patients, sorry, Ed, to mute yourself, because thank you. There are patients who are just more sensitive to the effects of radiotherapy than average, and there are certain conditions that make you more susceptible. But also, even within the normal population, if you don't have those conditions, there is a sort of bell curve. In other words, some people, you know, most people have an average sensitivity, some people are not very sensitive, and some people are highly sensitive. The second thing to say is, I always say to people, in the 4 weeks after each week of treatment, you do need to be more careful with your hands. And that's to avoid any trauma, whether it's friction type trauma. So for instance, people who do heavy weightlifting, people who sail boats and have ropes going through their hands, people who do mountain climbing. So that's sort of you know, physical trauma you need to avoid. I think you also need to avoid cold and hot as well. So getting things from the freezer, you know, doing very, very hot washing up, that sort of thing. So I tell people to avoid that. And obviously chemical type trauma as well. So you do have to be careful. And I had a couple of patients, one who was a builder who was lifting heavy concrete sheets without gloves. There was an obvious reason for that. And then there was one other patient who, she actually was fine, and then suddenly she got an upper respiratory tract infection. So she had a cough and a cold, basically, and she took antibiotics for it. And then suddenly her radiotherapy reaction got worse. And that's actually quite a known phenomenon, albeit rare in radiotherapy. It's called a recall reaction, where certain drugs can actually make the radiotherapy reaction worse. So the answer is, sometimes there's no good reason you know about, but sometimes there are things that you can avoid. So I hope I've answered that one. So there's anonymous, it says, can RD reduce lump size? But if I assume it's RT, reduce lump size, then the answer is yes, it can. From my point of view, as other people have said, you know, the issue really is of pain. So, you know, lump size for some people can be an issue in terms of fitting shoes, and also, you know, if people have got a small arch, then sometimes, you know, the size of the lump is quite important if you can reduce the size, and of course it takes it away from actually hitting on the floor or on the shoe. But for most people, even with a small lump, if it's very, very tender, that's more of an issue. So if you can take away the tenderness with radiotherapy, which generally you do, then really I think you've achieved what you need to do. So going down, Eric Foreman says, when you say 5.5 years follow-up, what do you mean by follow-up? So follow-up just means that they continue to either see or ask the patients how they are, and therefore they don't sort of lose sight of what's going on with the patients. So that was, I think, an answer about the evidence and the studies. I thought the standard process was 8-week break between treatments. Is the new standard a 3-month break? Well, I mean, certainly I understand that Professor Siegenschmidt now does 3 months, certainly for Dupuytren's disease. And I actually went to 3 months exactly because of the sort of side effect issue. There were some people that I used to do even 6 weeks apart, and they still had redness of the skin. And I really said to them, look, I think we should wait for another couple of weeks. So that's one reason, just to make sure that the side effects are better by the time we go to the second phase. The second thing is, you know, this is a very slow growing disease. So I don't think there's any rush to get the radiotherapy in there. And it might be that if you wait longer, that some of the cells that were not growing will then be growing 3 months later. So it makes sense to me to do it a few months later. What else? Have you found insurance often covers radiotherapy for benign lumps? The answer is some do, some don't. I'll be specific. Bupa always do. AXA never do. The others sometimes do. Okay, so I can tell you about the detail, but essentially Vitality does as well, WPA does, Aviva sometimes does. and then there's other smaller ones. But the thing to remember is AXA doesn't. So if you've got other insurance, it's worth a try. What else? Can I also have injections while doing radiotherapy? I have Dupuytren's aggressive form, got before 50, all over both hand, palms, thumb space. I think we're sort of maybe straying away from our subject if we talk about hands. And I'm very happy to talk to this anonymous person about their case if they live in the UK. But I think let's leave that for another time. What's the danger from trauma during radiotherapy? I would say it's really just about side effects. I don't think really there's any long-term suggestion that if you get more redness of the skin that you're going to do worse with the disease. But you know, there are certain circumstances where acute radiotherapy reactions translate into worse chronic radiotherapy reactions. In other words, if you get a worse radiotherapy reaction immediately after the radiotherapy, you might get more worse long-term changes. So to me, it makes a lot of sense to protect your hands. I mean, to be more specific, I do think that people, if there's any dryness, should moisturize. One reason is because if you've got very dry and cracked hands, you can get infections. What else? I forgot what I was going to say, but it's probably enough. Do you advise repeating radiotherapy at all? I've had both hands and feet done in 2018-19, and my feet, although no new nodules, remain quite sore. I still manage to walk and play tennis, but it's getting harder and I have to have bigger rest periods now. So let's just talk about repeating radiotherapy in general terms. Your skin and organs are only able to tolerate a certain amount of radiotherapy during your lifetime. However, you are able to recover a certain amount over time. So whereas I wouldn't want to give, let's say, you know, double the dose that I give, if you wait for, let's say, 6 months, a year or longer, then your skin and the tissue underneath will recover from radiotherapy. Now, it's unclear exactly what that recovery is. And in my view, I think we just have to be really cautious. So my practice is that if people have had a good effect the first time round and didn't get bad side effects, and they have an obvious change, in other words, that, you know, a lump has regrown, then I will repeat the radiotherapy, but I will only give 1 week of treatment, not 2 weeks. So I'm very, very cautious, but I have had some patients that have had a good response. I've not had enough patients that I've published anything, but I think that it is worth trying. I will say, just to be very clear, that at the moment when we talk about repeating radiotherapy, I'm talking about on the same area. So on the same foot in the same area. If you've got something on your other foot, on your other hand, whatever, you can do the full dose. But if you're treating the same area, then as I say, I would wait a year. I would want to know that there's definite evidence of worsening. So sometimes people's pain does go up and down, but I'd want to see a lump really knowing that it's getting bigger. And then I would consider repeating radiotherapy at a lower dose. And also I tend to treat a smaller area as well. So the first time round, I add a couple of centimeters around the lump. Second time around, I would restrict that amount that I add along. Okay, so what else have we got here? I had, they're moving all over the place. Do you advise repeating radiotherapy? We've talked about that. Just a statement, listening to this discussion, it seems that radiation has less of a risk than injections. I mean, I would say that the risks are different. I wouldn't say it has fewer risks. I'd say that it tends to be very well tolerated. We always have to keep in mind that radiotherapy does have a risk of causing cancer. As I say, it's a very, very low risk, but it's not a zero risk, and it can be serious. What do you recommend we patients do and say to our podiatrists to counter them if they want to operate? Well, let's go back to Grange Hill, just say no. Dr. Schaffer, how long can we expect radiotherapy to last? Well, I mean, you saw on the evidence I showed you that at 5.5 years, about 70 to 80% of people have still got a good effect. Does it last longer? The answer is probably yes, actually, but not in everyone. So I do find that some people have an initially good effect and sometimes it comes back and you redo it. In the Dupuytren's evidence, they have evidence up to 13 years and they still have a good effect for most people at that point. So I would say, you know, for most people, it tends to be long lasting, but not for everyone. What else? Why does radiotherapy stop the disease from progressing in the first place? So if you remember, I went back to, right at the beginning, I talked about the 2 ways that radiotherapy can help Ledderhose disease. One is what we call anti-proliferative, where it stops stuff growing. In other words, there are fibroblasts, basically the cells that give off the scar tissue that form these lumps. And it affects those, stops them coming there, stops them giving off the scarring, and various other sort of chemical sort of reactions going on there. And it also has an anti-inflammatory effect. So there's probably a degree of inflammation there, or at least processes that are like inflammation. And radiotherapy in these low doses can also stop inflammation. So I've come to the end of those questions. I don't know whether anyone, maybe any of the panel or anyone else has any other comments or questions?
Well, I actually had a question myself for you, Richard. I don't know if you mentioned it, apologies if you did. Do you have any experience in treating using radiotherapy in so you mentioned about a lot of the German papers using radiotherapy a lot, and a few of the papers coming out of there that have gone to surgical excision have found the best results with a complete fasciectomy and then followed up with radiotherapy afterwards.
Yeah, so I have seen that evidence, and they do quite well, actually. You know, my general thought about total fasciectomy is, you know, it probably tends to work just as well as radiotherapy. I mean, you know, I've seen figures 25% recurrence rate, and in those figures, they didn't tend to use radiotherapy after the surgery. So it might be that the combination of fasciectomy and radiotherapy does better. On the other hand, I would say, you know, and you know better than me, fasciectomy is a pretty morbid procedure with a lot of side effects and a lot of risks. So, you know, I have treated one patient who had recurrence after a fasciectomy, and he did very well. I've never given radiotherapy, you know, in the short period after fasciectomy. I would just say radiotherapy to me is so much less invasive than a fasciectomy that I would do radiotherapy before fasciectomy rather than doing fasciectomy with radiotherapy afterwards. Because there's no evidence that fasciectomy plus radiotherapy is better than radiotherapy alone.
No.
So to me, it just doesn't really make sense to do that. But, you know, it's not impossible that people will be doing a trial to look at that. But at the moment where we are, I just don't think the evidence is there for that approach.
Thanks.
Good. Thank you, Dr. Schaefer. And I think it's time to have a listen to what Dr. Ed Davis has to say.
Hi, good afternoon. Was on my iPhone. I'm back on the computer, and hopefully we have a good connection.
Yep.
Excellent. Well, I basically am trained as a surgeon in podiatry. I actually removed my last fibroma about a little bit over 20 years ago. The problem with simple excision of fibromas is as much of as a 70% recurrence rate. So, and I don't see how a surgeon can easily tell a patient, I'm about to do a surgery on your foot with a 30% success rate. It's just would be very hard for me to advise that. So a little bit over 20 years ago, on my last patient, we did a total fasciectomy, but I'm very aware of the consequences of removing the fascia. So I decided to rebuild the fascia utilizing a hernia mesh, which was a Marlex mesh. So the patient actually did pretty well, but and was fairly satisfied with the results. But when I looked at the foot, I felt that it looked too lumpy, and you know, maybe just my trying to be a little bit of a perfectionist, because the patient was happy, but I said, you know, I just don't like the way this looks. Do you mind if I try to remove the lumps? So I had at that time a product called Widase, which was made by Wyeth Pharmaceuticals, which is a form of hyaluronidase. And I injected that into the lumpy areas, and within a few weeks, the area smoothed out. I said, well, you know, I said, this is interesting. You know, if we have a keloid, we'll use triamcinolone mixed with Widase, and very effective in use of keloids. So it was just basing on that principle. It probably was several months before I saw my next Ledderhose patient, because again, there's not that many out there. It's presumably rare, although we can, that's a whole other subject. It's probably not as rare as we think. And I told the next patient, before we do surgery, why don't we consider hyaluronidase injection mixed with a little bit of triamcinolone? The patient said yes, and did that twice and was able to cancel the surgery. So it was very slow initially, and then as the years went by, my assumption was that the hyaluronidase was acting as a spreading agent for the triamcinolone. I mean, that was the common wisdom. Nevertheless, I introduced this technique to a number of colleagues, and a couple of the colleagues, for some reason, forgot to use the triamcinolone, just use the hyaluronidase, and seemed to get adequate results. And I thought that was very curious. Fast forward a number of years, what we're seeing is that the research, and again, I wish there was more clinical research, but we do have basic research on the area known as the extracellular matrix. The extracellular matrix was viewed as the glue that holds things together, a relatively passive entity. Since about 2013, there have been a number of papers that talked about the extracellular matrix, its functions, and that it is actually a place which is very metabolically active. More specifically, fibrosis may originate within the extracellular matrix. There's fibrocytes, fibroblasts, growth factors may have their source in the extracellular matrix. So the interesting thing is we can look at two different enzymatic approaches to the fibromas, one being collagenase. And collagenase is, the fibroma is primarily a type of collagen, although altered collagen formation. And collagenase is relatively nonspecific. Collagenase is marketed as Xiaflex in the United States and was officially approved for use in the hand. Although the way it's used in the hand is different. It was basically injected into cords, and after 24 hours, the orthopedic surgeon will break the cords. So it wasn't really used to involute a nodule. It was really used to basically soften the cords and allow those cords to be manipulated. So collagenase is something that could be used. I've seen some limited use of it in fibromas, not particularly successfully though. Hyaluronidase, on the other hand, doesn't really go after the mature collagen. It's really going after the extracellular matrix, specifically the hyaluron in the extracellular matrix, which we now think is the precursor tissue, the tissue that will actually generate the fibromas. And typically, what we'll do is we'll have a patient, and what we tell people is that on your fibromas, we're not going to get a lot of shrinkage with one shot, but we are going to get a lot of softening. And I do use ultrasound. It's not a requirement that you use ultrasound. I will tell you that we feel that we're all great shots, but when I put the needle into the fibroma, I can tell you that I'm low about 40% of the time. Now the problem is if you're too low, you're not causing any damage, but you're taking a fairly expensive injection and it's getting lost in the deeper tissues. If you're too superficial, not the hyaluronidase, but the triamcinolone acetonide or Kenalog, that will cause some atrophy of the subcutaneous tissue. So the goal is to try to be as central as we can. And I tell people, think of your fibroma as a rubber ball. I'm aiming for the dead center. And there's a couple reasons for that. We're trying to achieve a repository effect. And as mentioned briefly before, the larger nodules shrink faster than the small ones. And my feeling is that we gain a better repository effect on the larger ones. As they start to get small, the challenge is trying to keep the solution within the fibroma and minimizing leakage. Now, one thing we also do as the nodules get smaller, we're going to use less triamcinolone, and we may convert to pure hyaluronidase in order to avoid any side effects of subcutaneous atrophy. The problem is you're injecting a very thick lesion, and you cannot use a small needle, and you can't rush the injection. So it's something that we do very slowly with a large gauge needle, and because of that, I typically will do a posterior tibial nerve block to gain plantar Once we have the posterior tibial nerve block, we we then can do the injections, and the goal is to aim for the center. Obviously, when we speak of center on a sphere, we can envision what that center is. If it's oblong, if it's oval, obviously we may have several areas along the center. Some colleagues have believed that it's good to what we call peppered lesion, where you're using that needle and you're putting multiple punctures through it in order to spread the substance. We find that's not as good a technique because that creates more leakage. And our goal is to really aim for dead center, put as much into the dead center area as we can. Now, one of the problems is that you cannot use large volume. So we have to keep the volume small, and that's why we like the posterior tibial nerve block too, because if we put lidocaine or local anesthetics in the fibroma injection itself, we are creating some dilution, and keeping a good concentration is important. We will put a little bit of lidocaine in there, maybe a little bit of marcaine for long-acting effect once the PT block wears off. And then, for example, using my preferred product, which is Vitrace. Vitrace is actually ovine hyaluronidase, and was originally a product of a company called ISTA Pharmaceuticals, which is an ophthalmology company. That product was then taken over by Bausch & Lomb, which is an ophthalmology company. The advantage to Vitrace is that it's just more concentrated. Hyaluronidase, there are other forms out there. There's a product called Hylenex in the United States. And I believe the version that's used in Europe is Hylase, which is manufactured by Wockhardt Pharmaceuticals, or at least imported by Wockhardt. I think that factories maybe in India on that. The interesting thing is, we hear from the UK that hyaluronidase may be hard to come by. Well, there's a supplier in the UK. There is a supplier, and the people that are using it in the UK and Europe tend to be cosmetic surgeons, because when dermal fillers are injected, sometimes they become lumpy, and then the hyaluronidase injections are used to remove the lumpiness from the dermal fillers. So it's produced, it's used. It's just a matter of someone being willing to use it for this particular application. Now, first injection, we're going to get a lot of softening, not a lot of shrinkage. We like the patient to come back in 3 weeks. We say you now start with this hard rubber ball. Now we've got something that's a lot more mushy, like a donut. The second injection is a lot easier because we're going into a softer lesion. And then week 6 is when we see a lot of shrinkage. So one thing we're very good at seeing is at week 6, we get a lot of shrinkage. Then subsequent injections on a percentage basis will continue the shrinkage, but they do so at a somewhat slower rate. And as they get smaller, it becomes more challenging. We do use verapamil cream. And I think the issue with verapamil cream is that verapamil is a calcium channel blocker, and one of the recognized side effects of calcium channel blockers is atrophy of collagen. Now, on a systemic basis, that's not a good thing, but sometimes, as everyone knows, we take the side effect and use it to our advantage. Another blood pressure medicine was minoxidil, and they found out that it was good for hair growth, and that's guess using it for hair growth was more profitable to the drug companies than using it as a blood pressure medicine. In this case, verapamil, we're using it off-label. Now, is verapamil better than another calcium channel blocker? I don't know. There was a local company that got a patent on it. I'm not exactly sure how that occurred. And local compounding pharmacists had said, well, we can use other calcium channel blockers, and that may work too. I just don't have a lot of experience with it. So if the issue of obtaining verapamil is a problem, it's possible that other calcium channel blockers applied topically could have an effect. Keep in mind that you have to think about percutaneous absorption. One cannot expect to have a large round lesion apply a topical and achieve good absorption. So our feeling is if you're using that as a standalone product, you're going to be disappointed because the penetration is not going to be adequate to see a good shrinkage. But now, on the other hand, once you've reduced the size, once you've reduced the size of the lesions with injections or even radiation, I think that now you have a thinner lesion. In other words, there's more, as a lesion gets thinner, you have greater surface area relative to interior volume, and that's basic pharmacodynamics, what you need to get that in there. Then you start to see better results. The other purpose of verapamil cream, is actually to try to prevent new lesions from occurring, because you have to have something that's preventative. Now, I would love to see a combined approach. One of the problems we have in medicine and specialization is that we look at things through the lens of our own profession sometimes. And there's no question in my mind that the use of the enzymes can provide very rapid shrinkage, but there is no specific mechanism by which it's going to prevent new regrowth. I look at the universe of people with Ledderhose as those who get minimal regrowth, some get moderate regrowth, and some get aggressive regrowth. There's a term we use called whack-a-mole. When you basically knock one lesion down, another one pops up. Those are the aggressive reformers. So my opinion, combined approach, use the enzymes, let's get the lesions as small as possible, as fast as you can, and then apply a system to help mitigate regrowth, whether it's verapamil cream and radiation, because radiation has the, that is just a great mechanism to try to prevent regrowth. So that's really is it in a nutshell. I do have a lecture, but it's probably more time than to present it than we could do here, but certainly be happy to share the slides with anyone. We go through the history of the disease a little bit, and again, one of the things we emphasize is a target. I have a few thoughts on the issue of orthotics, and in the United States, I would say the majority of orthotics that we supply are done on a cash basis, non-insurance basis. And the problem is, if I have a patient with Ledderhose, I make them an orthotic, and we basically put an aperture or divot in the orthotic to remove the pressure from that lesion. Once that lesion is smaller, well, now that we have to alter the orthotic or make a new orthotic. And rather than try to think about providing this patient with 2 orthotics, I'll tell people, let's shrink this first. Let's get it as small as we can. Now let's make you an orthotic, once we have achieved some shrinkage, so we only have to use 1 device. Another issue that was mentioned is shockwave therapy. I'm a huge fan of shockwave therapy. It's used extensively in Germany. Its acceptance in the United States has been slow for a number of reasons. I'm not sure those reasons are scientific. We use it. I've not found it to be very effective for fibromas. It's an interesting concept in that we know that trauma induces new fibrosis in this disease process. Shockwave is a form of trauma, but then the question is, what type of trauma specifically is detrimental and what type of trauma is beneficial? There's a the main paper I've seen was by Dr. Knobloch, Knoblach, and he basically found that it was neutral. And my conclusion on shockwave for the fibromas is that it doesn't hurt and it doesn't help. I'm just neutral on it. I use it for other applications. So that really covers the orthotics, the shockwave. But I think the key issue on the enzymes is that for the first 20 years, I had no idea why it worked. I just knew that it did, and it was just something I did as a sideline of my practice. I mean, surgery is the largest part. But I think what's happened in the last few years, and there's more and more papers, and Anna was kind enough to provide a paper that we're really looking at focusing on that extracellular matrix as being metabolically active and the source of fibrosis, not just in this disease process, but in other disorders of fibrosis. One other item, just to be complete, is the area of nutrition. Yes, there's not a lot of research on nutrition, but I think this is a situation where we have to look at the cousins to Ledderhose, and one of the cousins is Peyronie's disease. And one of the treatments for Peyronie's disease is Potaba, P-O-T-A-B-A. Well, Potaba is just a potassium salt of PABA, or paraminobenzoic acid. So we feel that, and it's not extremely effective, but maybe 30% see some improvement with Potaba and Peyronie's disease. So we tell people to take PABA, paraminobenzoic acid, as a supplement. It's very inexpensive. PABA also is used for has other applications, just like a number of things. It may delay onset of gray hair, but and everyone gets a good laugh out of that. But but essentially, we find that there's some value in that. There's other supplements, and we have on our website that have a reputation of being beneficial for fibrosis, but we can't really say with any certainty that it's going to be beneficial in this particular case. But I think the way we look at the supplements, a lot of things are cumulative, and if we even get a 20% benefit from something like PAVA, which is extremely inexpensive, I think it's worth it. I think it's worth a try. Some other things that may be helpful are N-acetylcysteine, or NAC, again, very inexpensive, has some good anti-fibrotic effects, acts as a spreading agent, thins mucus. It's also it happens to be the antidote for acetaminophen overdose, which is very common in the U.S. So I think supplements are something, because those that are fairly inexpensive and have other beneficial and therapeutic effects, and even if it's a small factor, I think there's a benefit to trying those. They're not a primary treatment.
Ed, I don't know if you've noticed, Ed, but the questions are starting to come in.
Okay. Now,
if you
I
click
see there's
on
a
Q&A at the bottom.
Q&A, okay. So first question is, how many injections could someone have over the years and prevent atrophy? There's the reason that there's really no limit to that is because we can control the issue of atrophy. Atrophy is a function of technique, being too superficial. It's also a function of how much triamcinolone is put in, is used. In a large lesion where we expect a repository effect, we're not going to get a lot of leakage. I would use a little more triamcinolone, because the enzyme is the active product and the triamcinolone is more of the passive product, where, as mentioned, triamcinolone acetonide, or catalog, is an agent that induces atrophy. And this is a situation where we want to have some non-specific atrophy of that lesion to help the process along. As lesions get smaller, we can use hyaluronidase. I mean, hyaluronidase by itself doesn't cause atrophy. It's Hylenex is a common form in the United States, which is used for dehydration. If you found someone passed out in the desert and you couldn't get a vein, well, you could actually start an IV with your IV fluids, add Hylenex in it, and eventually the fluid would get into the vascular tree and allow one to start an IV. So hyaluronidase itself is other than allergies to certain forms, it is very safe, and it's not really a issue in terms of atrophy. As far as how often should verapamil be used, I think we got to look at that in terms of how effective, how much do we absorb with any given amount. So what we find is small amounts used frequently are better than using large amounts. There's been some advice in terms of applying the verapamil, using occlusion, adding a plastic or saran wrap to it. I think the problem with that is it's messy, number one, and if you make techniques more difficult, compliance decreases. So small amounts used frequently, applied 3 to 4 times a day while the nodules are active. Now, once the nodules are no longer active, or they're minimal, or possibly even gone, I like to tell people to use the verapamil once a day. And there's 2 reasons for that. Number one, we're trying to come up with a means of preventing new nodules. And number 2, just by touching them once a day, by rubbing, putting your hands on them, people are aware of what's going on, and because we've had people who do very well, and then a year later, oh my God, I've got the lesions are back. And well, when did you first notice that the lesions were coming back? Oh gosh, I mean, I just wasn't paying attention. So I think we just want people's hands there, just once a day, just to feel it, and that to see if an area is starting to get thick or becoming problematic. Obviously, we'd like to be able to treat when things are small. The next question is hands. There is no experience in use of hyaluronidase in the hand, to the best of my knowledge. There was one paper back in 1964 to that effect, but I went back pretty far back in history to try to find something. in theory, I could see a benefit, and I think it's something that should be looked at, but right now there is really no experience. The next question, can you get enzyme injections in the UK? I don't know if anyone's using it. Based on what I'm reading on the boards, it appears that no one has really used it. I would like to ask anyone who's using steroids and say, hey, consider adding some of this, because it is available in the UK. It's in the United States soft label. There's really, the issue of being off label in the US is that insurance won't pay, but it's still something that we can do. For example, if shockwave therapy is not covered in the United States, we still do it. So interestingly enough, shockwave therapy in the United States is only, in the foot, is only indicated for the insertion of the plantar fascia, not distal fasciitis, not the Achilles, yet we use it anyway off label because it does work. But it relieves the insurance company of the obligation to pay for that. The next, looking at enzyme versus RT. RT doesn't promise reduction. I think we see reduction in lesion size with RT. My general impression from experience is that it doesn't always reduce the lesions as quickly. I think what we can do is we can get fairly rapid reduction with the enzyme. So, and ideally, I'd like to see a system by which we got together and we would reduce lesions as much as possible if they are large lesions, and then follow that with RT. I think a combination approach would be good. The enzyme does not cause the disease to go dormant, which is the question. What we find is that if we look at the universe of people out there, as we mentioned, there are the people who are minimal reformers. So I think about 50% just don't form new ones. About 40% are moderate reformers, and those are the people we like to advise use of the supplements of verapamil. Now, we don't know if a person's mild, moderate, or a aggressive reformer. So we just tell everyone, use the verapamil cream, consider adding some of the supplements that have a reputation for being good for fibrosis. Then there's the 10% who are the aggressive reformers, and definitely those are the ones who I think that should be proceeding to radiation. Again, we don't always know ahead of time how to identify who is in which category. Interestingly enough, there are some people with very large lesions who we assume by the size of the lesions are aggressive formers, yet do very well with injections and have minimal recurrence. I think there was a question about what we recommend is different from straight catalog, and I think we mentioned that we are using an enzyme called hyaluronidase, which has various forms available, which would be hyalase in Europe. The supplements here from Jonas, we had mentioned the PABA, para-aminobenzoic acid. Again, there is evidence of its efficaciousness for Peyronie's disease. N-acetylcysteine, there is some discussion about oral enzymes. We don't exactly understand how they work, but we have seen some benefit with that. But again, we don't exactly understand how oral enzymes get to the peripheral tissues, and to what concentrations they would actually get to peripheral tissues. That's a question mark. Do enzyme injections affect the fascia beneath the lesions? Not at all. If anything, if there was fibrosis in the fascia, it would actually make that more flexible. We have occasionally, in cases of severe plantar fasciitis, one of the problems with plantar fasciitis, some people view it as being difficult to treat at times, but there's really three different types of plantar fasciitis. There's acute plantar fasciitis, which is more or less of a strain of the fascia. Obviously, something rest, ice, elevation, steroids, that will certainly help that. There's the people with chronic plantar fasciitis, where the fascia has become thick over time. That's usually a mechanical issue, and better shoe gear or orthotics certainly are very helpful for that. And then the third type is what used to be called intractable plantar fasciitis, and when you really look at that with sonography, you don't see inflammatory tissue. That it's really what we now call plantar fasciosis. And I have seen enzymes really to be beneficial for fasciosis itself and reducing the fibrosis there. So I think I've covered Eric Foreman wants to hear other people on the panel, and then certainly we address the issue of stiffness. But I actually use hyaluronidase for post-operative applications. At times, we do a lot of procedures for people with hallux rigidus. Hallux rigidus is a painful, stiffening, loss of motion at the first MTP joint, big toe joint, and what's happening is that on those particular individuals, when you try to restore range of motion surgically, there's still a lot of fibrosis about the joint due to years of loss of range of motion, and use of hyaluronidase injections in that application has been helpful in my practice.
I think that leaves one question by Eric Foreman, and the best person to answer that would have been George, but he's had to leave the session.
Okay.
So we'll ask him via email.
Can I answer that question with a question? Sorry, Ed, maybe I missed it, but can you just let me know, what's the actual evidence for your approach? I hear a lot of, personal experience and, talking sense, but obviously the way we assess whether treatments work is via trials or case series, and that would need to be a peer-reviewed process. So I'm just wondering what's out there in terms of support of these injections.
Sure. I mean, we have got to remember don't have research. There's no one doing research on this. We're trying to encourage that. One of the dilemmas is in getting interest in research is that let's look at for collagenase as a good example. The manufacturer of collagenase initially did the research and Dupuytrens. They then were expanding the research to Peyronie's and Ledderhose, and for some reason they discontinued that. That program where we were disappointed. Collagenase is a very costly drug in the United States, and to some degree, you in order to fund research, you a lot of times have to have a saleable product which will provide adequate return, to the manufacturer. So right now there is no patentable form of hyaluronidase. It's a very old product, although there's different forms. So there has been no incentive to get research. I've talked to a couple of manufacturers, and again, just the not seeing a patentable form, we haven't been able to encourage them to do research. We do, we recognize that we would love to have the research. But it's a matter of getting a major university center here to do it and to fund it. We do recognize that experiential evidence is a form of evidence, especially when the numbers are good. And I think that we have a situation where we've had quite a few patients, probably over 1,000 in 20 years that we've treated. We in the last 3 to 5 years, a number of other people who have adopted it and have had very good results. So our results appear to be very good from an experiential point of view. And yes, of course, we would love to have a major drug company, major pharmaceutical company, university sign on to research on this.
Sorry, just to make myself clear, I mean, when I say research, what I don't mean is a major clinical trial. What I'm talking about is just publishing your results. Because, patients do ask about, does this treatment work? Does that treatment work? When we come to have to answer those questions, there's nothing out there for hyaluronic acid, nothing out there for supplements of various sorts. So it's all opinion. And I think that, even when you talk about your experience, which, obviously is very valid to talk about, if things haven't actually been published in papers, it's really very difficult for other people to assess whether we believe it, whether we think that it's reasonable, whether we think it's dangerous actually, because of course, any treatment has its side effects, and whether, on balance it has benefits and how we would compare it to other treatments. So that would be my comment, you know, as part of the panel.
Sure, I think the issue we would all love to have every treatment have the type of clinical trials you talk about, and that's basically a fundamental precept of evidence-based medicine. But if you, and I've talked to a number of experts in this area, if you look at the medicine that's practiced today, approximately 30% of medicine as is practiced, at least in the United States today, has that level of research and evidence. So essentially, you know, obviously, if you said, well, gosh, we don't have that for the other 70%, we don't throw that 70% out because there's significant experience throughout history based on things that work and don't work. So yes, you know, if we said we're only going to do medicine and healthcare practice based purely on the criteria of having the double-blinded multi-centered studies, that's going to cover 30% of what's done in terms of the entire body of medicine. You know, you look at things like surgery. Where are the trials and studies on surgery? I mean, they're very small. They're very small studies, and they're very small studies, and for the most part, they show very poor success rates. So, so essentially, and yet surgery is covered by insurance and is considered an accepted treatment. And surgery is certainly much more dangerous. So I think that you know, if we're going to hold this very high level of criteria out, we have to, for this particular treatment, we have to hold that same criteria out for everything.
I'm just encouraging you to publish your results. That's all.
Right.
I'm not trying to say your treatment doesn't work. I'm just saying, for us as professionals, when we assess whether treatments work, these are the criteria that we use, and we don't have another way of assessing them. So all I can say is I just encourage you to publish your results so that we can all see how good your results are. That's all.
Okay.
Right, I think that brings us to an end of our webinar on Ledderhose. So all we need to do is say thank you very much to all our speakers, to Gary, George, Marcus, Richard, and Ed. It was really informative, and I hope everybody got a lot of answers to their questions. Thank you, everyone.
Thank you.